Peter.
Good evening, everyone, and welcome to our Physician Wellness Program run by KMA in collaboration with KPA. Today, we are having a topic on occupational health, and Dr. Nelson is going to guide us through. Dr. Nelson Pekethu is a medical officer with an interest in occupational health, currently working with the Directorate of Occupational Safety and Health under the Ministry of Labour. We're hoping this is going to be a very interactive discussion. So the first 25 minutes, Nelson is going to take us through his presentation. Then we have about 20 minutes to engage in a discussion, question and answer. So feel free to write your questions as the presentation is going on or to ask them after the presentation. Dr. Nelson, thank you very much, and take us through the discussion.
Okay, so thank you very much. Give me a minute as I try to share the presentation. Dr. Nema, could you kindly give me about 5 minutes to just try and set up the sharing settings? They're a bit challenging. Just give me a few minutes.
Sorry, I'm muted. So the program is about physician wellness and looking at some of the key aspects that make up physician well-being. My suggestion or recommendation, particularly for 2023, would be getting sufficient sleep to enable you to be able to make decisions well, to be able to concentrate and focus on the things that you're working on with clarity, to be able to exercise, which is very important for mental health. So sleep between 6 to 8 hours. I know a lot of people say that's not possible, though it's actually 7 to 8 hours, but most people say they can sleep on a 6-hour day, and that is sufficient for them. We don't know about the long-term effects of that, but I think the recommended time for sleeping works well for performance, productivity, excellence, and it really allows you to make decisions well. So it gives you clarity in decision making. It allows you to concentrate better than when you're not well slept. It allows you to focus well and to focus on what you're focusing on, because sometimes you know what you're focusing on, but then you're not focusing on what you're focusing on. I hope that makes sense. It may help with maybe procrastination. So if you have, let's say, residual feelings of something negative that happened to you that is still persisting, and then you're not sleeping well, that can play a role in inhibiting you from being productive. So from being able to achieve the goals that you set, from being able to set, realistic goals using the SMART metrics, so specific, measurable, achievable, realistic, and time-bound. So you're not very practical in the way you approach things if you're not well slept. Your mood gets affected. And what they've shown is that particularly for doctors, when they're sleep deprived, this was a study on residents, is that their mood gets affected on a brain that is deprived of sleep, but their cognitive function isn't. And so you sort of work like a machine. You're able to make a diagnosis, you're able to write your history clearly, you're able to give proper treatment, but then your mood, meaning your engagement with the patient, is affected. So you may be a bit rude, or you may not be empathetic. You may think maybe you're trying to be, but because of the deprived sleep, it takes a lot more energy for you to show compassion. So sleep, sleep, sleep. Nelson, are you ready?
Hi, Doc.
Uh-huh.
So I'm not able to share the presentation, but I've shared it with Peter so that he can probably project from his end.
Okay.
Yeah.
That's okay. Yeah. So I'll continue with my rambling about sleep if you don't mind.
It's all right.
And Dr. Neema, I don't know
Yes.
if I know Peter had mentioned he may not be able to be around unless we have another assistant, just so that we are not waiting on Peter and no one else. And then
Oh,
he did.
yes. Yeah. Can you
So-
send it to me then? Let me share my email address.
Yes, I can forward it to you as well, Doc.
And
Just a
maybe
minute.
that as that happens, Neema, I think I can just keep helping you. And I remind all of us that we are meeting here for our own mental health, our own wellness, and we plan to meet every Tuesday. And I know many of us healthcare workers are used to focusing on patients, but I hope that when we meet here on Tuesday, the reflection is on us. The messages that are shared are our messages, not for those people out there. Is the concept of physician heal thyself. I know we are not just talking about doctors. I know we have nurses, we have psychologists, we have clinic officers, we have all of us, but all of us really will help us. And we want to, especially in 2023, ensure that we are focusing on that aspect of our own wellness. We have seen, unfortunately, as healthcare workers who are at the forefront giving health, they're the same ones who are drinking. We are the same ones who are dying of liver disease from excess alcohol use. We are killing ourselves much more than is reported, unfortunately. And many people have that concept of what will the serikali do? And I want to say this is KMA, this is the healthcare professionals' way of saying, before the serikali can saidia us, we are here to help ourselves. And we hope that that is a spirit we are going to carry on, that you cannot give health if you don't have health as a person. And Dr. Koba is my name, part of the Kenya Medical Association Physician Wellness Committee, and we are a team. And I know we also have representatives from other organizations that are joining us. And the hope is that as we go along, we will keep encouraging each other, supporting each other, so that no healthcare provider dies because of the stresses of life or because of the things that we could really prevent. And that's the spirit of these meetings, and we encourage each other to keep sharing. And if you have a topic of interest that you think that you'd like us to discuss, please feel free to continue sharing, even on the chat. And you can also email us, or you can just share with us, so that we make sure that we are meeting you at the point of your need. Thank you very much. Back to you, Dr. Neema. I hope you have managed to get a minute to get the email. And while at it, I know that I have seen Dr. Kigondu here with us as we wait for that presentation. I don't know whether Dr. Kigondu is also would like to say something. I see he's the co-host. He's the chairman of Kenya Medical Association.
Thank you very much, Edith and Dr. Neema. I'm actually the president, Chairman Elisha. I want to thank you for this webinar series on mental health. And there is a big gap that is actually there, and it is important that we continue as medical workers to continue keeping well, so to speak, as was aptly put. You cannot serve from a cup that is empty. And therefore, as we continue, we encourage all health workers to continue listening to these webinars that we are hosting as the association, and also to make use of the call center that is being run at the National Nurses Association of Kenya, and also to come out should they feel that they are losing it, so to speak. So with that, I think I will hand it back to Dr. Koba, and hopefully Nelson will have gotten ready, because we are eagerly waiting for this. In the recent presentation that I made to finalists, to students in a stethoscope ceremony, occupational health came out very strongly. It is important to educate our medical students also on the dangers they may have in terms of occupational health. And this topic is very timely, and we are eager to hear what Dr. Nelson has for us. And as we speak, we also encourage members to renew their membership fees for their various associations, and to keep the association running. Thank you very much.
Thank you very much, Mr. President. Yes, sorry, how can I reduce president to chairmanship? I apologize. On a light note, I think Dr. Neema, you can tell us whether you are now ready with Nelson to keep going.
Unless I use, it's taking some time to open. It's taking a bit of time to download on my side. Unless I use the email to project, if that would be acceptable. I could.
I don't know one of the things I believe that even before we had the what are they called? Even before we had the PowerPoints and things like that, we were still able to keep going. So I'd encourage Nelson, as long as he has his presentation and he's audible, he can keep sharing. Yes. As Nelson, you keep maybe Neema tries to project or look for a way of projecting. But yes, I think we can keep going, because I know you have a message, Nelson, for us. So you should never feel like you're stranded just because the PowerPoint didn't work. I'm sure you have a message for us, and we're happy to receive it.
Okay, so thank you very much once again, Dr. Neema and Dr. Edith, for giving us this opportunity to discuss about occupational health, specifically with that related to healthcare workers. So as I hope I'm audible to everyone.
Yes, I can hear you.
Okay, thank you so much. So as a brief introduction, as Dr. Neema had mentioned, I'm Dr. Nelson Pekethu. I am a medical officer and a practitioner of occupational safety and health. Currently, I'm based at the Directorate of Occupational Safety and Health under the Ministry of Labor. So there's a medical division whereby we work from there. Now, occupational safety and health, basically, it refers to the safety and the health of workers. And the health and the safety of workers is not just in the healthcare sector, but it's basically all sectors of the economy. Whether you're talking in the manufacturing sector, the communication sector, in the healthcare sector. So it covers a very broad area, and basically tries to look at the safety and the well-being of workers in their different workplaces. And the objectives for today are going to basically try to get a general overview of the occupational health and safety services globally. Then you try to narrow down to the Kenyan situation, how the occupational health services are structured or are offered. And then I will further narrow it down to specifically the healthcare sector and try to look at the important or the key occupational health issues affecting different cadres of healthcare workers. We'll also try to look at some of the challenges that we currently face in terms of offering occupational health services to the healthcare workers in this country, and probably some of the ways forward, some of the solutions that we are looking into and we are working on to try and expand that bracket and to make sure that people in their various workplaces, especially healthcare settings, are able to access occupational health services. So as a general overview, if we look at occupational safety and health, it's generally abbreviated as OSH, Occupational Safety and Health. And it mainly encompasses both two main aspects, occupational diseases as well as occupational accidents. What I can probably take you slightly back to some of the incidences that have happened in the recent past. And I think we can all remember the issue of one of the general workers in some company in Thika, who unfortunately fell into a boiler, and they of course succumbed to the injuries that were sustained. So that would be a classical example of an occupational injury or an occupational accident. And those are accidents that can generally happen within the workplace. And there are very many measures that are taken and that the government or the Ministry of Labor tries to look into to make sure that such workers are safe wherever they are working. There are also the other big aspect of occupational diseases, and these are basically medical conditions that can arise as a result of you working in a specific place. So for example, in the case of healthcare workers, it's a very real risk to contract a disease like HIV or hepatitis B or even tuberculosis in the course of your work, or in your wherever you work, whether it's in a hospital, a lab, maybe if it's a Cambridge Center or any other research facility. That's a real possibility, and you can be able to contract such a disease. So those are the two key areas. The other thing that occupational safety and health deals with is issues of compensation. So when workers get injured or when workers sustain various occupational diseases or accidents as a result of them being in their workplace, for example, someone who might slip and fall in the workplace and undergo a fracture or sustain a fracture, for example. And because of that fracture, they are no longer able to work for a certain duration, or they get what can be referred to as a permanent incapacity. Maybe that joint becomes completely deformed and it can never go back to normal. How then are they compensated? And what is the role of the government in making sure that those workers are compensated as it's supposed to be? So that's the other thing that occupational safety and health services deals with. So if we were to look at a global perspective, or from a global perspective, there's our World Health Organization and the International Labour Organization estimates, and the numbers currently are around 2 million mortalities or 2 million deaths annually from occupational hazards. So occupational hazards, as we may have alluded to earlier, are things in the workplaces that expose us either to injuries, occupational injuries, or occupational diseases. So because of those occupational hazards that exist in different workplaces, the WHO and the ILO, the International Labour Organization, report about 2 million mortalities or deaths annually. From their breakdown, about 80% of all those mortalities are basically due to occupational diseases, while the remaining 19% deaths occur from occupational accidents. Those are now injuries, people falling over from heights, if it's in a construction site, for example, while the 80% that we mentioned is mostly from occupational diseases. And to even put this into further perspective, when you look at those specific injuries that happen, not all those injuries or not all occupational diseases that happen in our workplaces lead to mortalities. Those that lead to injuries, some of those injuries they disrupt the quality of life of different workers, and therefore that leads us to DALYs, the disability adjusted life years. And this basically is a combination of all the people who die prematurely because of those accidents, or those who sustain certain incapacities that alter the way they live their life because of either that occupational disease or that occupational accident that happened to them. And from the WHO estimates, those are reports about 90 million DALYs. And that's a significant effect, because when you look at those, the disability adjusted life years, these are people whose earning capacity is affected in one way or another. If someone was a breadwinner, then their health is going to be affected. If, let's say, for example, they have sustained an injury that has affected how they are going to work or how much output they can have. If, let's say, it's a surgeon who has sustained an injury and they're no longer able to operate. So already that means that that's a whole career that has been altered in one way or another. And so even when you look at the compensation mechanisms or the matrices of doing the compensation, that has to be factored in as well. So there's a huge economic burden that comes to it, apart from just the loss of life and death. One of the things, if you look at those 2 million deaths that are occurring every year as a result of occupational diseases and occupational accidents in the workplace, one of the leading occupational hazards that has been attributed to causing the largest number of deaths is exposure to long working hours. And the ILO and the WHO, through various studies, have concluded that risk of long working hours, if is anyone working more than 55 hours per week. So that in itself poses a significant risk to health, and it has been attributed to be a major contributor or the leading cause of mortalities. That 81% number of deaths that we saw are being caused by occupational diseases. The biggest contributor or the biggest risk factor that has been identified is exposure to long working hours, which the ILO and the WHO have estimated to be about more than 55 hours per week. And that puts a big number or a big percentage of healthcare workers in that specific category. Most people, or in most office setups, they would probably do about 40 to 48 or 45 hours per week. Most healthcare workers, on the other hand, especially the ones who mostly work in shifts, most of us would end up doing more than 55 hours a week. And that's a significant risk factor that basically puts us in that red flag that we need to be aware of. The second largest contributor is basically occupational particulate matter, and that refers to the particles that are in the air in various workplaces. Maybe in the healthcare setup, it might not be that significant, but at times the hospital setup might be next to an area where there are a lot of particulate matter within the air. If it's maybe situated somewhere like at the river, or a place where like Bamboo, where there's a lot of dust particles or particulate matter within the environment, even if it's in the working, even if the source is not in the healthcare setting, then that still puts you at a risk. And we can see that's the second leading cause of those deaths that are due to occupational hazards. And the other thing, which is significant, especially for healthcare workers, is gases and fumes. And this, of course, would be related to people who work in the lab, the pharmacists, or people who work with the chemotherapy combination, where they're combining the chemotherapy drugs, and there are a lot of fumes. So if there aren't proper measures to make sure that these workers, whether it's in the lab, where they are dealing with a lot of these agents and their gases, some of them are very volatile, and there are fumes which are being produced, then it would be important for them to make sure that they are well protected against some of these hazards. Another group, of course, is biomedical engineers, people who work with the equipment in the healthcare setup, whether those equipment have broken down and they probably need to be repaired once in a while, and there's a lot of welding happening. Those fumes would also be a risk factor for these groups of healthcare workers. They might not be dealing directly with patients, but since their work is predominantly within that healthcare setting, and their risk is, or the exposure is in the healthcare setup, then they have to be considered as well. So now we can narrow it down to the organization of the healthcare, of the OSH services, the Occupational Safety and Health Services within the country. So the way the OSH services are organized is that we have the Ministry of Labour, which has the overall mandate, and one of the key departments under the Ministry of Labour is the Directorate of Occupational Safety and Health Services. And that directorate, as the name suggests, it basically is like the umbrella body when it comes to occupational safety and health services within the country. So, and that ranges from inspection of workplaces to make sure that they are fit for workers, to doing things such as medical surveillance, to look out for occupational diseases, and to look out for the health of workers in different workplaces, including healthcare settings or hospitals. So under the Directorate of Occupational Safety and Health Services, there are certain other divisions. There are divisions that, there's a division that mostly deals with the aspect of compensation, and there's also a medical division that mostly deals with other medical issues like what we've mentioned about medical surveillance. And in terms of the legislation that the directorate operates under, or the legislation that basically covers OSH services in the country, that's basically the OSH Act of 2007, as well as the WIBA Act of 2007. So that is basically the Occupational Safety and Health Act of 2007, together with the necessary, the subsidiary legislation that usually comes with that, and the Work Injury Benefits Act. The other thing that is also important in terms of guiding what we regularly do on a daily basis are the international standards that have already been put in place, especially those that have been put in place by the World Health Organization, as well as the guidelines and the laws and the standards that have been put in place by the International Labour Organization. The ILO is like the worldwide or the global body that deals with issues of workers, whether it's safety of workers as well as the health of workers in different workplaces. And Kenya has been a member of course, the ILO since 1965, and there are a lot of conventions that we've ratified. And therefore, even in our daily activities in the provision of occupational health services, we have to make sure that we still consider and abide by those conventions. So that's the general organization of the occupational health services within the country. And now we can narrow it down further to specifically the healthcare setup or the healthcare workers and some of the important occupational hazards that healthcare workers of different cadres are exposed to, and some of the health outcomes that we might be able to get from such occupational hazards. So we've categorized them in about 4 or 5 categories. We'll try to expound on each category as we probably create more awareness on the same. So the first category is basically that of infections. So those are what we can call biological hazards. Any healthcare worker who is working in a hospital setup or a research facility, for example, like Cambridge, or any other research facility, whereby infectious agents are being handled, or where you're dealing with people who have come to seek healthcare. These are patients who might have certain health conditions. There's a possible risk of you contracting some of the conditions that you're dealing with on a daily basis. Even the patients that you're treating, they might sometimes, in some cases, you might be able to contract some of those conditions. And those are some of them are quite straightforward. Some of the most obvious ones include tuberculosis. We know it's a big burden, especially in this part of the world. And as a healthcare worker, especially people who work in TB clinics or who see some of these patients, the respiratory physicians or chest physicians, some of them interact with them on a regular basis, and therefore they have a very real risk of contracting some of these conditions. Another one is, of course, hepatitis B, and I'm sure most of us are already vaccinated against that. And it's a very real risk, again, especially when you're dealing with body fluids. We know hepatitis B is about 50 or so times more infectious than HIV. So again, it's an important aspect to actually consider. HIV, of course, there's always a risk when you're working with patients who are HIV positive. There's always the talk of needle pricks. In terms of the transmission of HIV through accidental pricks, it might not be very significant, but the risk is still always there. So in terms of looking at these infections, the categories of healthcare workers that would be more exposed or at a higher risk are, of course, the clinical staff and even the lab staff, as well as other guys who are especially doing research, like in the research centers. So the doctors, the nurses who are taking care of these patients, if there are clinical officers who are involved in the management of these patients. We're also talking about the people in the lab, from sample collection to analysis of samples. All those workers who are involved in that whole chain of taking care of that patient, even people in the radiology department who are usually involved in getting or covering chest x-rays for these patients, there's always a risk of sustaining or contracting some of these conditions. And that, of course, based on the mode of transmission or the possible route of transmission of some of these occupational conditions, then that informs some of the protective measures that people take. For example, in the chest clinics, then use of masks or the regular face mask could be an important aspect of using a personal protective device in order to try and take care of, protect the worker in this particular situation. When it comes to contact with body fluids, whether it's, when it's collecting blood samples or collecting sputum samples, then also using the mask as well as using gloves would be very important. In terms of needle pricks, that's why they are the sharp boxes that are provided in all the sample collection areas, whereby needles might be needle syringes, and any other sharp devices like all those sharp devices can basically be used as a route of contamination, or as a method in which the healthcare workers in that particular setup can be able to acquire some of these occupational diseases. So based on the type of infectious agent that healthcare workers are exposed to in different areas, then that informs the type of PPE or personal protective equipment that healthcare worker would use in order to protect themselves. Another important hazard that would probably mention is radiation. And when you talk about radiation, one of the main areas that we want to think about is the radiation suits in our hospitals, and specifically the ionizing radiation. The ultrasound and MRIs are not so much major risk in terms of ionizing radiation. So in this particular case, we are mainly focusing on the X-rays as well as the CT scans, because those ones use ionizing radiation. And in terms of the ionizing radiation, if you look at the Radiation Protection Act of the country, that's CAP 245, it clearly outlines that if a hospital setup has been given a license to operate a CT scan machine or an X-ray machine, then there are certain minimum requirements that healthcare facility, in this particular case, the licensee, must fulfill, or there are certain measures that they have to take in order to protect the worker or the radiation worker, whether it's a radiologist or radiographer who is going to be in that environment. And that's why you see one of the things that has to be implemented is the dosimetry monitoring. And the dosimetry is, I'm sure most of you have seen the radiologists and radiographers wearing a dosimeter, which is basically a gadget that is able to measure the amount of radiation that this healthcare worker is being exposed to. So there are certain limits which we're going to discuss specifically when we are discussing the radiation exposure to radiation workers. And so the other thing that the law requires for hospitals is that there must also be records that have been kept. So all these dosimeters, they need to be monitored on a regular basis, and there must be records that have been that the hospital keeps. And apart from those specific records, these radiation workers also need to be examined at least 6 months in order to be able to see whether are there any adverse healthcare conditions that they have developed as a result of their radiation exposure. And that also brings in a very important aspect, that all these records, once all these records have been kept, then as staff from the Directorate of Occupational Safety and Health do their regular inspection of facilities and workplaces, those are some of the records that actually need to be availed, as well as the medical examination of workers. From the time where the workers are being onboarded into the company, whether it's a hospital, then there has to be a pre-employment medical examination, as well as the annual or the periodic examination that workers are being taken through. The other important thing, of course, is now the exit medical examination. Once this radiation worker has worked in that place for 5, 10, 20 years, then and of course having undergoing the annual or the periodic medical examination, at the point they're exiting, then they still need to undergo an exit medical examination, just to confirm how their health status is. Are there any issues that have arisen? Are there any occupational diseases that have arisen in the course of their 5-year or 10-year or 30-year employment as a radiation worker that is directly attributable to this particular radiation? So those are some of the key things in the Radiation Protection Act that would apply in our setup. Of course, another group of of workers that would be exposed to radiation would be the dental technicians and the dentists as well. So when you talk about still on these radiation workers, the dosimetry basically calculates the amount of radiation that has been absorbed in the tissues as a result of the ionizing radiation that these workers have been exposed to. And in terms of the limitations or the guidelines that are there, when you look at what the dosimeters do, they basically count in terms of the whole body or the total body exposure to radiation. Although we know that certain organs of the body have different threshold for exposure to ionizing radiation. Some tissues are more are more susceptible to damage, or some of them even to genetic mutations as a result of exposure to radiation. And there's a whole table that shows which organs are more susceptible, or what is the limit for each organ. But usually what the dosimeter measures is the whole body exposure to the radiation, or the absorbed radiation, and that's usually around 5,000 rems per year. So that's basically the limit that has been set in most of the jurisdictions, and the records are regularly inspected to make sure that the whole body exposure does not exceed that particular set limit. In terms of, so the unit of measurements is rems. I don't think that's very important for this particular discussion. And the dosimetries come in different sizes and designs, of course, based on the manufacturers. But the underlying principle is that they need to measure, or they need to measure the amount of radiation that is absorbed in these healthcare workers, and they even give a monitor. They basically bleep or give a warning once that limit is about to be reached, and it helps in monitoring. So apart from radiation, so the other major occupational hazard, or the other major risk that we are concerned about, especially for healthcare workers, are the ergonomic hazards. And the ergonomic hazards are basically the musculoskeletal injuries. And ergonomics basically deals with how the body or the muscles and the tendons interact with the working environment and the other forces within our working environment. And by that, we basically try to see, are there any health conditions that are arising either from excessive use of certain muscles or certain tendons, or probably having to lift a lot of weights, or having to perform jobs that have a lot of repetitive movements within the course of your day-to-day activities. And one of the commonest and one of the biggest implications for economic hazards is especially on the nursing cadre. And we mainly pick on the nursing cadre because of the type of work that they do. Most of them, especially in the critical care settings, there are several papers that have been published. Most of them have to, change the patients, they turn their patients, they clean their patients. So they're always bending forward, lifting patients. If patients are on outer seal drains, sometimes they're bending over on the floor to try and check, take all those measurements. So there's a lot of movement that they usually undergo. So a lot of back pain, neck pain, feet pain as well. Most of the times they're on their feet. Of course, even the other healthcare workers have this particular hazard. They still undergo this particular hazard. The doctors, if you're on a 12-hour shift and you're on your feet and you're probably on uncomfortable shoes that probably are not well fitting for you, or probably high heels, then of course you're at the end of the 12-hour shift, you're going to start experiencing some back pain because of the strain that your muscles are undergoing. That's a very big economic hazard. Is a very big or a significant type of hazard, especially in the healthcare setting. And we've actually seen quite a number of nursing staff, especially in the critical care unit, even have to change their job description because the back pain is progressive and it is too severe for them to continue doing the same type of job. They're not able to keep lifting patients. They're not able to keep bending over and being on their feet 24/7. Some of them have to move to probably other departments that might be less demanding, or have to play other roles that don't involve a lot of physical work because of their injuries. There are those who even sustain severe muscle sprains. Maybe if two nurses are on a shift and they have to do that to like lift and turn patients by themselves for a whole maybe 6-hour or 12-hour shift, then the strain that they're going to undergo is going to be quite significant. Or if you're a doctor who is on a 12-hour shift and you're probably the only doctor with very many patients, then you're on your feet the whole time. And of course, that points us back now to the issue of human resources for health, which is an important aspect, as well as the ratio of, let's say, doctors to patients, as well as the ratio of nurses to patients. So, and that has a huge implication in terms of the economic hazards that these healthcare workers are exposed to. The other stuff is especially now the biomedical engineers who have to do a lot of manual activities, either with with spanners as they try to repair those biomedical equipment. Maybe some machines have failed. The welding that they probably have to either supervise or they have to do for some of those machines. That's another risk. When them bending over, them sustaining wrist sprains, they also expose. There's a real risk of repetitive strain injuries, as well as the carpal tunnel syndrome that they can also get as a result of their day-to-day activities in the workplace. Not forgetting the other group of healthcare workers that don't necessarily treat patients. And this is maybe the guys who are in the management, people who are in, let's say, the finance sector, within the hospital setup. They are still within the hospital setup, and they can still, apart from them being exposed to the biological hazards because of them being around the hospital, they also have their what you can say unique to them, some hazards that are unique to them. If they have to like sit from morning to evening in the office, let's say the account staff, managing accounts and looking at all those numbers and preparing statements for patients and doing all the work of printing and everything else, that in itself also is a risk, is an economic hazard. If the chairs that they are using and the desk that they are working on are not well aligned, if their feet are probably hanging from the edges of the chairs, then that's another hazard that they can basically get. And most of them will always be complaining of back pain, neck pain, and wrist pain. In terms of the structure of the chairs that they're using, are those chairs well designed? Are they actually economic chairs that have necessary back support? How is the desk that they are working on for 8 or 10 hours? Is it a desk that they have to strain every now and then? If they have to reach out for something on the desk every now and then, maybe they have to reach out for printing papers, which are probably underneath the desk. So every now and then they're always bending over and straining. So that's also another group of workers in the healthcare setup that are exposed to those specific hazards. So in terms of economics, the commonest one is usually back pain for most of the cadres, whether it's the doctors and the nurses, and it's a very real risk and hazard, and it can be quite debilitating for some staff. There are those who, even as they age, because of osteoporosis and all the other changes that happen with age, it becomes very, very debilitating for them, and some have even to retire early enough or earlier than they had anticipated. So it's a good thing that it's a thing that we need to actually take note of. And when it comes to pre-employment checkup of healthcare workers, that has to be factored in. Most of the time, or in most of the high-end hospitals, workers usually undergo their pre-employment medical examination. There's a few tests that are done here and there. In some places, the tests are quite thorough. In some places, the tests are not very thorough. But it's good for us to actually take note of those specific tests and those specific pre-employment medical examinations. For the healthcare workers that are probably always on their feet, the doctors and the nurses, as well as people in the lab, then especially the nurses who have to be lifting patients and turning them and cleaning them, then there's a lot. We need to incorporate a lot of OSH training and on-job training as they continue to do their job, so that they learn how do they lift weights, how do they how do they turn patients around. And also to encourage what we call a multiple person task, so that the nurse doesn't have to do it by himself or by herself. Then if maybe the patient is very heavy and the nurse is not able to do it, then there should be at least another nurse to also help to be able to do that, so that you reduce the risk of these hazards, these economic hazards taking place. And of course, the issue of increasing our nurse to patient ratios, that's also very important. For the workers, for the lab technicians or people who work in the lab, most of you have seen the height of the bench workers versus the stools that are mostly in our labs. Those end up injuring our lab staff a lot, because they're definitely not ergonomic. They have no back supports. Some of them are a bit too high and uncomfortable uncomfortable height to work under. Some of them, when they are seated on those very high stools, their feet are dangling. So all those are factors that need to be put in place from the initial stages that even the lab itself is being set up. So there has to be that that incorporation of an economic design of the workplace, especially in this case, let's say the lab, to the needs of this particular worker, so that at the end of the day, the worker is not injured as they are performing their day-to-day activities. One of the biggest hindrances to some of these things is the long time that it takes for this exposure to cause symptoms. Some of the symptoms start very insidiously, and they may take a very long time. And if someone is not aware, if some of the healthcare workers are not aware of them, then you might even never think that it is related to your workplace. You might think you injured yourself running out there or working out, but it's actually because of your posture at work. If you're always seated on the lab bench, if you're always seated maybe in the office as you're a hospital administrator, then those are issues that would probably not cross your mind, but it's a good thing that we're actually aware of them. And even when it comes to treating patients who are coming to us, some of them are our fellow healthcare workers, and it's important for us to be aware of some of these exposures that they might be undergoing, which might have caused all their medical issues. So especially for the issue of back pain, which is one of the economic hazards, some of the things that we basically try to recommend a lot is provision of dedicated lifting teams, where the either patients are very heavy, then the actual lifting teams that can be able to help the nurses do that. Some institutions have what we call stewards or nurse assistants or patient assistants who help with a lot of the manual work that is done in the hospital, therefore ensuring that the nurse is not exposed to a lot of physical strain that will actually kind of wear them out. Training them in manual handling, we already mentioned that. Ensuring that we give them adequate rest, looking at the working hours, and making sure that their shifts is, if you do like 2 or 3 shifts, then you take maybe 3 or 4 days off. Some of them even, they might find heat or cold therapy helpful, especially when they're experiencing either neck pain or back pain. And of course, you mentioned comfortable shoes. That's also another important aspect. Moving on to the other major hazard in the healthcare setting is psychosocial hazards. And I will not go very much deep into this, because I think in the previous session, Dr. Edith really went into the mental health aspect of healthcare workers. So this is to do with issues such as burnout of healthcare workers, compassion fatigue, depression, anxiety disorder, drug abuse. I think Dr. Ed did a very good job on it. So I won't delve so much into it, but that is something that we need to take note of as healthcare workers. Remember, she elaborated very well on, if you've been exposed to all these traumatic issues in the ICU, seeing patients dying and relatives crying, you give them so much compassion to the point where you have nothing left. And, she, of course, mentioned the issue of pouring from an empty cup. If you have nothing left for yourself, you're not able to take care of other things. Drug abuse, I think she also mentioned that she went into great detail on that. One of the things that we hope to implement, or we hope to slowly create awareness on and make sure that people embrace it, especially in the healthcare setup, is the inclusion of a mental health assessment at the point of pre-employment and also during the annual medical examination of workers. Healthcare workers being workers, some of them might not see the essence of doing some of those medical examinations, but they are actually needed based on some of these hazards that they're exposed to. And considering that there's an increasing and a huge burden of mental health issues among healthcare workers, this would be a very important step, making sure that even from the get-go, I know some of those forms that we fill when we are starting our jobs in various hospitals, they might probably have a small question of, have you ever had any mental health disease, or have you been treated for any mental health condition previously? And then it ends there. But it needs to be more comprehensive so that it can actually capture people who have a significant risk for mental health conditions, and be able to link them to care and be able to follow them up, so that even as we discuss this with medical directors, with hospital administrators, and even with the other doctors and other healthcare workers, then they are aware that mental health is not just something that is brushed off or something that is just left to one bullet of the questionnaire, that it's actually an important aspect. And if we can have an actual doctor doing it, or even a psychiatric nurse doing it, someone with some knowledge on it or with significant knowledge on it, and someone also who has access to systems of linkage in care, then that would actually be important, and it would be able to even raise awareness of mental health amongst ourselves. Some of the times we are very in a lot of denial about mental health conditions. So there's a table I have here as I conclude, as I wind up, on some of the exposures in terms of the chemical exposures or the chemical hazards, which is the other big group in the workplace. For example, chemicals like benzene, which are commonly used in the lab, can give us an adverse health outcome of leukemia. Things such as formaldehyde that are used also in the lab, as well as even in the mortuaries, which are still healthcare settings, have their own adverse health outcomes. The aromatic polycyclic aromatic hydrocarbons as well, they have their own health outcomes, such as CA lungs, CA trachea, and bronchus as well. So there's a whole list of the dose as well as the duration of exposure is a very key factor to consider. Someone who has been exposed to benzene for 20 years is not the same as someone who has been exposed to benzene for 1 day, and even the dose that person has been exposed to. So there's that list. I hope you'll be able to see it once we share the PowerPoint. Some of the challenges that we currently face in terms of offering occupational health services to workers, especially in the healthcare sector, is of very few medical experts. There are very few consultants or doctors who have gone into the field of occupational health. And I think the more we have such sessions where people are aware that it's actually a branch of medicine that is also very important in terms of our health and our well-being, then we can have more people training to be able to offer the same services. The other major thing is sometimes it's very difficult to prove causality. So like when you're saying that this occupational disease has been caused by this exposure, some of those exposures are not only found within the healthcare setting, they can also be found in other environments. And at times it's very different to say that this exposure was found in a certain place. Like, for example, the time of COVID, it's very difficult to know whether you got a COVID because you're working in the hospital or because you are with a COVID patient in a matatu. It would be, sometimes it's a bit difficult to pinpoint the exposure and to be able to show that cause and effect. In other cases, providing total protection from specific hazards might be a challenge, and that's where now the provision of personal protective equipment comes in all workplaces, including the healthcare setups. We talked about gloves, talked about provision of sharps, talked about certain procedures and policies that health workers have to take so as they are not exposing themselves to some of these hazards. When it comes to the legislation, there are also some challenges there and some gaps in terms of being able to produce a comprehensive list of the possible occupational diseases that can result from various exposures. There's also a limited access to the informal sector of the economy, although that is not so much within the healthcare sector. So those are some of the challenges that we experience, such as in the healthcare sector, in terms of provision of occupational health services. In terms of the way forward, or how we are all trying to make this more functional in our systems and in our sectors, is making sure that we are creating awareness in all workplaces. And we are very glad that we're able to have a chance to discuss occupational health, specifically in the healthcare setup, so that we are all aware of some of the things that we not only face, but even some of the conditions that workers can present with. And the answer would probably be in the history that we are taking. When we are taking the history and finding out where have you worked, for how long have you worked, then those can also be clues as to some of the conditions that they're suffering from. Training of more healthcare workers, that would be very, very instrumental and very useful, and that is currently ongoing. The other area is, of course, collaboration with private entities such as private hospitals and even other government agencies such as the Ministry of Health. We are currently having some research trying to figure out, as we collect data in different workplaces, as we get people's blood pressure and blood glucose and checking their weight and their height and their BMI. Is there a way we can use that as a screening tool to provide data and also to benefit the patients, especially for the Ministry of Health as they come up with things such as a step survey and as we also try to create a database of our own country. So those are some of the areas of collaboration that we are hoping to expand further, and even as we continue to create awareness on this particular issue. So that's basically the end of my presentation. I would like to take it back to the moderator so that she can guide us from there on the Q&A session.
Thank you very much, Dr. Nelson. That was a brilliant presentation and very persuasive. I'm thinking some of the people listening here might be thinking of going into occupational health. I'd like to reintroduce myself again. I forgot to do that initially. My name is Dr. Neema Araka. I'm a psychiatrist and I'm your moderator for today. So I can see that we already have some Q&As, but I'd like to start with one on mental health particularly. You mentioned that occupational accidents and injuries and diseases. And my question to you is, we have evidence to support that hypertension can result from workplace stress. And hypertension, being a chronic illness, tends to be associated with depression and anxiety. So if you were to look at the compensation to assess the occupational hazard in this particular patient presentation, how would that go?
Okay, thank you very much for that. That's a very good and a very interesting question. Now, one of the challenges that I probably mentioned is in terms of the gaps that we currently have on the legislation. If you look at our Work Injury Benefits Act, there's a schedule attached to it, which is a list of some of the occupational diseases that can result from some certain exposures. If you go through that list of occupational diseases that are listed in that schedule of our own laws within the country, there are very huge gaps in terms of some of the conditions that we currently know are actually occupational, such as hypertension because of our long working hours and strokes. They are actually missing from that particular schedule. Yet, if you go to the ILO website, International Labour Organization, you're able to find some of those conditions that are listed. The challenge with that would be the compensation, the calculation of compensation. When it comes to the calculation of the compensation, the schedule that gives us the percentages of, this person has been injured, maybe they have cut a certain proportion of their finger, so they'll be awarded 5% or they'll be awarded 10%. The issue of occupational diseases, the schedule is very silent on occupational diseases. What it suggests is that it's actually what's the correct word to use? It's the directorate or the ministry to come up with those percentages for most of the occupational diseases. One of the things that has to be considered, or one of the things that is actually being outlated in the current legislation, is on the people who develop occupational diseases and they need some sort of long-term medical assistance, or if maybe they have been bedridden or they require maybe oxygen supplementation for a long duration of time, then that should be arbitrated by the Directorate of Occupational Safety and Health, and the employer is actually supposed to be able to fund it. Although the timelines or the time frame within which and for which that should be provided is also not very, very clear. And it's actually it's something that is open for discussion. It's an area that when we have more and more medical experts or occupational health experts on board, then it will be very easy to actually be able to come up with such for us to be able to discuss. Someone has developed stroke. Maybe they've been working for all these years, and that's why with long working hours, they have developed hypertension, and it has ended up with a stroke. How then do we compensate them? Because currently we don't have such elaborate measures of compensation. And that's one of the current gaps, the challenges that we have, which we hope that as the field grows and as we have more medical experts on board, then we can be able to have such elaborate compensation matrices.
Okay, so key message is more medical officers to get on board with occupational health. Let me read you some of the questions we've got. So more than 55 hours, does it mean that OBs OBGYN are more at risk or most affected from working long hours? Any studies done?
Okay, thank you very much for that. So generally, I think not just OBGYNs, I think generally for most of the healthcare workers, of course, we know that there are certain fields of medicine that are more hectic than others. There are certain fields of medicine that probably you have to put in more emergency hours because of the emergencies that arise. And therefore, it would go without saying that if you're in a field where you have to put in more hours than the average person who is doing 40 hours or 45 hours, then for you, the risk is higher because it means it's almost like working in a survival mode, because there's always you're always working under a lot of adrenaline rush. You know, there are emergencies left, right, center. Someone is delivering over there, a baby is somewhere else, there's a PPH over there in that other corner. So it's like you're working on survival mode 24/7. And of course, that is not good for your health. So I would say, yes, there are some fields that would probably be at a higher risk, and that is purely based on the exposure that you have, like the number of hours that you have to put in. I'm assuming that if you are in a place where you're not having to put in a lot of work, whether maybe you're in management or you're the head of A&E somewhere, and maybe you only might see 1 or 2 emergencies in a day or maybe in a week, then for you, your risk is slightly higher as compared to someone who's working in the intensive care unit probably, or who is having to run code blues every now and then.
Okay. Next question is, what type of mental health assessment would you recommend for pre-employment check?
Okay, thank you for that. So that's an important question. It's one of the things that we are really discussing amongst ourselves and hoping that we can create a sort of a basic tool to be able to screen workers, and that would involve the history that we take as we do pre-employment medical examination. Has this person ever been diagnosed with any mental health condition, or are they currently on any treatment? Have they had any risks? For example, maybe is there a family history of certain mental conditions? When they are in such a stressful environment, how is usually their reaction? How do they react? Do they at times feel like their life doesn't mean anything? Do they feel like they don't have anything much to offer even in such situations? So we currently don't have a proper mental health assessment or as a tool, but those are some of the things that we are thinking that we could probably incorporate, as well as also having psychiatrists like yourself on board, so that you can also give us a lot of input, so that we don't have a very comprehensive tool, but we have at least some minimum things that can be used, so that we can now be able to see, now these people seem to be in some sort of risk and they might probably need some sort of care. Or even the ones who have already been diagnosed with certain mental health conditions, then we already come up with employee wellness programs whereby they're included and they're on constant follow-up, because some of them actually missed even from the point of entry. Maybe I might have been diagnosed with anxiety disorder, but since no one ever asked me about that, then I still come to work, I get my job, but maybe when I'm having panic attacks and I'm at work and my work is affected, that's when that issue comes up. Yet it would have actually been identified from the word go, and it would have been given the necessary and the due attention.
Okay. We noted about the mental health input for assessment. I'm thinking you're looking at something very specific and targeted to the job description.
Yes.
Mm-hmm. Okay. Someone is asking, how is DALI calculated or assessed?
So how is DALIS?
DALI.
Mm-hmm. Okay. So DALIS is basically
Yes, loss to disability.
Yeah, so it's basically the loss in terms of either the loss of life. That's basically the premature death that someone might sustain while they're working. And then also at times, even if you have not died, when you've sustained an injury that basically limits your working, like how you the job that you are doing, if maybe you are able to earn a certain income, or if maybe you are able to work for 5 days a week, but now 2 of those days of the week you have to go to the hospital because of your injury, or because of your of the condition that you've basically sustained. That is what is used to calculate the total DALIs, and it basically involves the years lost as well as the productivity that is lost. For example, there's someone who dies, then that person has basically lost certain years. If they were supposed to work until they were 55 years or 60 years up to their retirement age, but now they have died at 30. So those remaining years are considered, as well as someone who the productivity level, someone who has not died, but their productivity has been affected. Maybe they have to take more than usual sick of days, as opposed to any other person. That's also factored into the calculation of the DALYs.
You indicated about 90 million years lost to occupational hazards, yeah? And I know we have the same for depression. About 50 million years are lost to disability. And in US, they've done a study where they can actually quantify that employers lose 11 days over 3 months due to depressive episodes. So the data is there. Perhaps we need to replicate it on our side as well to see.
Yes, maybe just to add on that, one of the things and one of the reasons why we need more healthcare workers in the occupational sector is because a lot of this data is, of course, like in the US, it's data from the WHO and the ILO. So we would need healthcare workers with a lot of medical knowledge to also be able to do studies in our area, so that we can see what is the true burden in our own setup. Because that would also give a lot of impetus to the call for, occupational health services within the country. It would also give a lot of, it would help to attract funding to be able to offer occupational health services. So yes, we need our own data as well.
Yeah, very true. I have 2 questions. Number 1, any healthcare worker that sustains injury, for example, an accident while on transit to or from work, or during work hours as a result of tasks assigned, does that injury fall under DOSH? It's interesting. The second question, same person, when employees come to have their DOSH form filled, who compensates them? Is it the employer, insurance, or the government?
Okay, so to answer the first question, the OSH Act of 2007, that's the Occupational Safety and Health Act of 2007, is very clear on what an occupational accident is. However, so what it actually says is that the time when an accident is considered to be occupational accident, especially when it comes to people moving around or transit, is if the transportation is as a result of the employee. If the employee is one who has offered the transportation. There are some companies, for example, that give buses that pick their workers maybe from town to their offices in Upper Hill, or maybe if it's the ambulance that is transporting you, if it's the employer who has provided his own means of transport to the worker, and then an accident was to happen, and then someone sustains permanent incapacity, that is what the law basically describes. However, as you can imagine, that is also arguable in a very real and very very onto the ground issue, because the example that my colleague is giving is very real. You've been called to the hospital, but you're using your personal means, and then an accident happens, and that's because you can even prove the phone call from the nurse covering or from the ambulance line calling you, but just because you are using your own personal means, it might produce a sort of a gap in terms of you actually seeking or claiming compensation. So that's also another area that we also need to give our own input, even as healthcare workers and as workers in general, so that we can see how then do we go around some of those challenges. The issue with also some of these laws is that they were adapted from other jurisdictions without really having to fine-tune them into our own setups, and that probably is a discussion that we all need to have. The next question is about when DOSH 1, part 2 of DOSH 1 is filled in the hospital, who compensates that person. So once that form has been filled, the compensation is done by the insurance company. So as an employer, apart from the employer giving you the regular medical cover that they're supposed to give you as a healthcare worker or as any other worker, then there's also something called a WIBA cover. So when we come to do workplace inspections, for example, when I come to hospital, let's say it's Nairobi Hospital or whichever hospital, one of the things that the HR, we want to check with the HR is that apart from having a medical cover for the employees, they also have a WIBA cover. And a WIBA cover is exactly that. It's a work injury benefits act. It's like another insurance cover that the employer takes to basically make sure that these workers are covered in case of an injury or an accident in the workplace, as far as WIBA is concerned. If you get the regular pneumonia or the regular common cold, that is not covered under WIBA. It's covered under your regular medical cover. But then your employer usually is supposed to have another cover called a WIBA cover that is supposed to compensate you. So it's the insurance that pays, the insurance that caters for you. However, that process of following up and making sure that, one, the accident has been reported within the appropriate timelines, and that this employee has been fully compensated, and actually the right employee, because there's also a lot of fraud, that the right employee has been compensated, that is not what falls under DOSHs. So basically the procedural bit of it, making sure that the employer has actually followed the necessary steps and that this worker has been compensated, because even the compensation happens in the DOSH offices. When that check is written, it's supposed to be issued from the employer to the employee within the presence of a DOSH officer, and there's a form that has that all the three sign to say that this process has been completed from the time the accident was reported to the time the compensation has been done.
Thank you. Still on the same, on that compensation, you mentioned that there are some healthcare workers who deal with a lot of traumatic events in their patients, so they endure vicarious trauma. If they require compensation in terms of time to recover, in terms of going to see a psychiatrist to get treatment for that, does the company cover that? Or do they have to take their sick leave to deal with that?
So ideally, the company, or rather the company's insurance, is supposed to cater for that in terms of all their leave days, because one of the things that is also considered in that compensation, when we are doing the calculation for compensation, apart from looking at the anatomical loss of function, let's say maybe someone has had a stroke and maybe their right upper limb is not working, the other thing is also that is considered is their hospital bills that they incurred. Who paid for that, for the hospital bills? Was it the employer or was it out of pocket by the employee? And also the sick off days that they took. That is what is sometimes referred to as temporary incapacity. The number of days that this person was on sick off, yet they were probably being paid. So were they being paid while they were on sick off, or were they actually being paid? So that is referred to as temporary incapacity. If they're able to go back to work, then that is also considered as part of the calculation. So ideally, the employer is supposed to pay. And even when it comes to people who sustain a permanent incapacity and now they have to be on some sort of medical assistance for a prolonged duration of time, the law states that the employer is supposed to pay or to compensate them, although that discussion is supposed to be had with DOSHs actually.
By any chance, would that include bullying at work?
Mm-hmm.
Or other forms of harassment, sexual, toxic workplace, severe workload hours?
Yeah. So basically, the mental health issues that would arise from
directly.
Yes. Ideally, also that is supposed to be catered. However, under the existing legislation, if you look at the list of occupational diseases, it's currently not listed there in terms of our local legislation, but we know for a fact that you being in this particular workplace, you being exposed to these extensive working hours is actually a risk to your health. And that's why there's a part of the legislation that talks about there having been an arbitration, like now it's under the jurisdiction of the director of OSH in the country to be able to assign a sort of a percentage or to consider that as well, or to include that within the schedules. But that's a very real thing, which again is why we need more healthcare workers in OSH, so that we can be able to discuss some of those issues, which are very real.
You're doing an effective job at motivating us towards that. The next question, I think, is building on mine. You mentioned that long work hours is at the top of the list when it comes to occupational health-related morbidity and mortality. What, in your opinion, and I know this is a global issue, has been the hindrance in creating policies in healthcare to curb or regulate working hours This is especially at a time when numerous studies have shown the link between long hours and poor patient safety. I think we have about 5 more minutes and then we can come to a close.
Okay. So I think for me, at least from what I've read around and from what I also believe and from what I see on a regular basis, in terms of some of the stories you hear from workers in different sectors of the economy, the biggest issue, in my opinion, is basically capitalism. So everybody wants to make a quick buck from maybe taking advantage of workers in one way or another, because that in most of the instances, that is what leads to most of the occupational accidents and even most of the occupational diseases. The fact that most employers, they want to minimize their costs so that they don't provide personal protective equipment. They don't want to have flexible working hours. They still want you to come to the office for 10, 12 hours, yet it is something that you can actually do from the comfort of your house. In terms of what you've mentioned about patient safety and the long working hours, especially in the healthcare settings, if we could be a little bit more humane and care about each other instead of just focusing more on the profit margins, then I think that would probably be one of the ways of trying to curb this. So I think for me, it's capitalism. Ni tamaa tu inasumbua watu.
I think this is a straightforward one. How often should the dosimeters be replaced?
I'm not sure of the exact timelines, but what the legislation talks about is six months. But there needs to be regular calibration. But maybe I can check on that in terms of the specific timelines for their replacement. Maybe I can check on that and just confirm.
Okay, I think we have 2 more and then we can wind up. Very informative presentation. Is there compensation for healthcare workers working in mental health units who face violence from their patients? If so, does this compensation also include damage to property while in the units?
Ideally, yes. Because you're in a workplace, let's say, for example, if a mad person, okay, not mad, someone who is mentally ill, for example, and they're violent, then they hit you with something, or they bite your hand, and you have like a permanent mark on your skin, that is some form of disability, and that can actually be compensated. I think the biggest issue or challenge is that most of the times we are not very aware of how to even start that whole compensation process. You being on sick off, you undergoing rehabilitation, you undergoing counseling, that is also part of the compensation. But such an accident, it should ideally be reported, and if there is some sort of permanent incapacity from that, then it should also follow the due process. That would be the ideal situation to follow.
So what is the current situation? You say ideal quite a lot.
Yes, the current situation is that for most people who have undergone some sort of violence, even from patients, it's just reported as an incident within the hospital, and then it ends there. It never even reaches DOSHES, because the law is very clear in terms of the accident reporting. Either the worker who has been injured can report directly to DOSHES so that the whole process can be initiated, or the employer can report to DOSHES, or even a third party. If you hear your friend underwent XYZ, you can also report that directly to DOSHES and have the necessary forms filled, and also have the incapacity assessed. So that, but now that currently doesn't happen a lot. For most people, what happens is that once they have injured and it's been reported as an incident within the workplace, then it ends there. Most of the time, even many health workers in such units don't undergo the rehabilitation that they need, because most of them will have the fear of dealing with these patients next time, and and that also brings in some degree of neglect of patients who actually needed that care. Yeah.
And the last question: what mechanisms are available to an employee to compel employers to adopt appropriate occupational health measures? I think it builds on that response.
Yeah. What mechanisms are there to enable workers, compel employers to follow OSH regulations? All right. So basically, as per the provisions of the OSH Act and the WIBA Act, there are certain minimum requirements in all types of workplaces. For example, in the healthcare setup, maybe, which is probably what you're dealing with today, if you look at the mental health units, to just use the example that you had mentioned, then there should be OSH committees And I think most workplaces have OSH committees. And those OSH committees include both members of the management, members of the HR team, and also workers in different departments. And that's actually a requirement under the law. And one of the things that we also come to check is, if let's say I come to the hospital, and once we come to the hospital, we want to get the minutes of the OSH committee minutes, and see what recommendations have those workers in those different departments have they given for implementation to the employer. And now it's up to us to confirm, have those recommendations of the workers been implemented? Because at the end of the day, those recommendations are for the safety and the health of the workers. And in as much as they are not laws, they are not enough regulations to be able to describe all types of workplaces, then that's why now the workers have a role to be able to come up with areas or issues that have to be addressed, especially if it's issues related to their safety and their health. And once now that has been picked up by maybe DOSH's inspectors, then now the DOSH itself can be able to force the employer to be able to implement some of those ways or some of those recommendations, because there are also certain fines that have been stipulated in the OSH Act if some of those safety regulations have not been met.
Okay, so this is a closing question. It's on the comment section, not on the Ask Q&A. Which healthcare field has the highest occupational hazards, and what type of hazard?
Which
healthcare field has the highest occupational hazards, and what type of hazard?
Okay, so answering that, not using our local data, because there's very minimal local data on that, what we can probably say, or what we can extrapolate from some other studies in other parts of the world, basically healthcare settings or healthcare professionals that one have to work under very intense or survival mode. Basically, the people working in the emergency, in the emergency field, people working in pediatrics, people working in OBGYN, so workers who, as well as intensive care units. So those are the groups that seem to face a lot of pressure, and they seem to be always on survival mode, and they seem to be developing a lot of health issues, such as, mental health conditions because of burnout, because of emotional fatigue or compassion fatigue. So those are some of the fields that have basically been identified so far. Of course, in all the healthcare fields, in as much as those might be the ones that are ranking at the top, the others follow closely, because you're still a healthcare worker, you're still a doctor, you still encounter these patients, maybe not as a big emergency they're coming in, but you can already feel their suffering, and you feeling their suffering is also a risk factor for you. So those are some of the fields that have been identified to basically be at the top, but that is based on data that has been done in many other places, not really our own. Yeah.
Thank you very much, Dr. Nelson, for making the time to create such an elaborate and educative presentation. I've learned a lot. I'm hoping others have too. And thank you everyone for making the time to attend and for making it very engaging, very well elaborated topic. Thank you, very informative. Thank you, well done. These are positive comments you're getting. So I'll pass it to Dr. Simon Kigondu, the president of CareMed, to see if he's got any announcements. Thank you for this opportunity to moderate at the CMA. Dr. Simon Kigondu.
Yeah, thank you very much to Nelson. I think this presentation will be available at the YouTube page of the Kenya Medical Association. And we remind people to continue paying their annual subscriptions and continue joining us in these webinars every Tuesday and Thursdays between 2 and 3. With that, I want to thank Dr. Nelson for a good, excellent presentation. And we will see you next week. Again, the reminder is that the presentation will be available at the KMA YouTube page from tomorrow. Thank you very much.
Okay. Thank you too.
Thank you and have a wonderful evening.
Thank you, and thank you, Dr. Neema Araka, for the great facilitation and moderation. And team healthcare workers, we look forward to meeting next week. Our health matters. Let's keep at it. Bye-bye.